Thank you very much. I'm very happy and proud to be with you guys. This is a fantastic gathering, and we keep seeing more and more activities, surgical activities, and this is the beauty of, like we are looking for, I'm the president of the Saudi Society of Intervention Cardiology. So what we love and to see more and more is like a heart team meeting, like more surgical people to come at our intervention and more interventionists come to the surgical meeting, but just be nice with them when they come. So without further ado, my talk about the percutaneous tricuspid valve intervention. All of you know that tricuspid valve disease is a bad disease, and it is associated with any degree of tricuspid regurgitation with different, heart failure symptoms, either the reduced ejection fraction or the preserved ejection fraction. Severe tricuspid valve regurg is associated with less survival at all the forms, the mild, moderate, and severe compared to somebody with no tricuspid regurg. So tricuspid regurg is a bad disease. Tricuspid regurgitation per se is an independent risk factor for all-cause mortality. And even if you adjust for atrial fibrillation, mitral regurg, LV dysfunction, pulmonary hypertension, RV dysfunction. This, and I think it's an important slide because, whenever we discuss a case, we would just focus on one thing. Oh, there is a LV dysfunction, or, there is a pulmonary hypertension. I keep hear this a lot from our surgical group, either at the Saudi Virtual Hospital or our institute. They just focus on pulmonary hypertension, and they really they don't focus on the degree of the tricuspid regurg, not the severity of tricuspid regurg and RV dysfunction. And this is why I believe that right heart catheterization should be done in every patient. It's I'm from a background of a congenital intervention, so I truly believe right heart cath, it should be revived and in a proper way. This is a well-known slide for everyone. TR, RV dysfunction, then everything fell after. Clinical course and progression of right side heart failure and tricuspid regurg. You can see it's a linear relationship, visceral congestion with mild fatigue, persistent visceral congestion, malnutrition, and hepatomegaly, then, irreversible organ damage, and then what usually we see with tricuspid regurgitation that is not good candidate before for intervention, like fatigue, peripheral edema, hepatomegaly, and ascites, and all this disabling finding. The early intervention is better than late intervention. Step by step, my name is right side heart failure. This is, I'm just like gonna skip some of the slides because this well known to you, echocardiogram, and don't be hesitant to order MRI, and it's a very important modality to assess the RV volume, LV volume, and even it can give you idea about the degree of fibrosis and the damage in the wall of the heart chambers. Again, right side heart failure, right side and left side diagnostic cath is very important. Some of the tricuspid valve regurg is primary tricuspid regurg, probably in our region is rheumatic heart disease is common comparing to somewhere else, and then it is the other reason either related to the left side heart failure, related to recurrent pulmonary embolism and RV failure, or device implantation like ICD and CRTD. So the way how to manage such patients is to try to fix the reason in addition to medical therapy. Surgical outcome for tricuspid valve surgery. It's a scary data, and the number of the patients included in every study is huge. Look, 5,000, you rarely see this number in intervention cardiology. 5,000 patients isolated tricuspid valve operation between 2004 and 2013. You always see that the in-hospital mortality is very high. And of course, the more severe is the tricuspid regurg, is the more severe, is the more in-hospital mortality and less survival. And this is, as you see in the slides before, we are not looking at a valve that I need to repair. Already the patient is, the majority, they have too many organ failure, and they have RV failure. RV failure is very difficult to recover in all the pathology except ASD, percutaneous ASD or surgical ASD repair. There is no improvement in long-term survival with surgery versus medical therapy. This is a study included about 3,000 patients. And then the trajectory, you can see that they divided the patient in this, it's about 1,768 patients. They divided to them according to a MAID score. This score is age more than 70, NYHA class 3 and 4. You remember from the slide I show you, usually class 3 and 4 symptoms, it's with severe tricuspid regurg and well-established RV failure. So then right side had a fatigue sign, taking 2 more than or 3 bells of furosemide, filtration rate less than 30, elevated total bilirubin, ejection fraction less than 60, moderate to severe right ventricular dysfunction. The more the score is classified as high, then intermediate, and then low. As you can see, the group with the high score, whatever you do for the medical, surgical, repair or replacement, they do bad. If it is low score, I think this is an important score to know, is the mild form, the low score, they do better with repair comparing to surgery, and comparing then to medical therapy. The intermediate, the repair is clearly superior to replacement and medical therapy. So replacement is bad. Not bad, I mean like is not superior to medical therapy, but repair is superior to everyone. And this is why in our practice, we never send patient for replacement, and usually I send for repair. After do extensive study, I have a good experience with Dr. Adel Tash. We did like, at least in my institute, about 13 cases. So what is the replacement for surgery is trying to do percutaneous. You can see that it is the four type of tricuspid valve intervention, annuloplasty, different modality. Some of them is out of the market, not out from the market, not out in the market. And it is a lengthy procedure. Sometimes you will finish the case with a good person with incomplete achievement of what you are looking for. It's a very comprehensive technique. Then coaptation, the triclip and Pascal and Dragonfly and Mitralex. The most common between this is the first two, the triclip and Pascal. Then orthotopic replacement, evoke, interbed, and the rest. Some of them it's an investigation, and we're going to launch the evoke in Saudi Arabia during the TCT Middle East in April, and we'll invite every one of you to attend. And then the heterotropic replacement, like the trach valve, and this is always for patient with, in the stage. Too many trials running on. The tricuspid regurg, if you look at the outcome of the majority of the modality we used, like angioplasty or tricuspid clip, there is improvement in cardiac output, and then TAPSE and pulmonary artery systolic pressure and nutritional status of the patient. And there is too many registry. It shows that tricuspid clip doing something, to reduce the tricuspid regurg, percutaneously improve the quality of life. And there was a lot of studies and presented in London Valve 2024. This is just a quick summary. And the majority of the trial revealed that there is, with different modality of percutaneous therapy, revealed there is a decrease in morbidity, but mortality is still a big issue. And at least we can improve the quality of life of such patient. Transcatheter tricuspid intervention, because TR is matter, it's safe, make a patient feel better and happier, bears the hope for prolonged life, and there is no single study show that so far it improves survival. How many minutes left for me? 4? So let me just show you a couple of examples about what we do. So this is a tricuspid clip. This is a case done by Fahad Al-Qahtani from King Fahad Medical City in Riyadh. He helped me send it to me because my movie was not working on arrival here. So this is a severe tricuspid valve regurg. This is an intra-procedural echo. Very important. We see the coaptation line, the separation between the leaflet, and this is a very important view for us, which is the transgastric view. And you can see it's a beautiful tricuspid valve here in regarding of the length of the leaflet, and the separation is not wide. Here is almost 3 to 4 millimeter. Anything above 6 is bad. So this is after deploying the clip, and so usually we show you the good result, the good cases, but not in all the patient you see the such beautiful result. And because too many things, like most of the center in Saudi Arabia, except the military hospital in Riyadh, we do probably between 8 to 12 cases per year. And that's because we are not able to recruit patient. The military almost finished 100 case, and the second bigger center is King Fahad Medical City, King Salman Cardiac Center. They are doing pretty good. And so this is the image here, same patient. That's before. As you can see, that's a really big TR. And then this is after the tricuspid clip. There is 2 clips here used in this patient, and you can see clearly there is good reduction in the tricuspid regurg. So the problem with clipping is when you sedate the patient, the tricuspid regurg is reduced. Even if you increase the blood pressure by medication, you are probably increased by inducing tachycardia, which is not enough to recruit the venous return, and that's why you don't see a good tricuspid regurgitation. So we go and we clip as much as we can, and then once the patient awake, probably they end up by between mild and moderate, if you want to name it. So this is the 2 clip, and an excellent result. Then I'm going to show another case. So this is a valve-in-valve. A 31-year-old male, extensive past medical history, VSD surgical closure during childhood, tricuspid valve repair at the age of 15, tricuspid valve replacement at age 21, Edward Life Science surgical valve size 29, atrial flutter ablation at 22, transferred for valve-in-valve for degenerated tricuspid valve, severe TR, severe TS, mean pressure gradient 14. Our echo observation revealed severe pulmonary valve regurg and degeneration of tricuspid aortic valve, of the tricuspid valve. CT and MRI ordered. This is ECG, and look at his RA is huge, and RV is also huge. he's also having severe pulmonary regurg. So this is the MRI here. You can see that the RV is big. In all the classic, in all the, can I have this? It's like another 2 minutes. So this is the first reported case and accepted in Euro intervention 2 weeks ago for publication. Show me the,
Can you get that slide back, please?
Please. Okay. So I will make it, you can see here, the tricuspid valve, the 29, look at how huge the RA. So this is an angiogram revealed the distortion of the RVOT and some aneurysm because of previous surgery. So make it short, this is what you see up here is the transcatheter self-expandable pulmonary valve, the venous valve. We implanted successfully. The gradient was a single digit and there is no paravalvular leak. And then on the way back, I did the Mayval valve in valve. And this was about 2 or 3 years ago. Patient is doing great. There is significant reduction in his RV size, significant reduction. But the RA is still large and his arrhythmia symptom is decreased. So this is the first case report of self-expandable pulmonary valve, venous valve, and tricuspid valve in valve at the same setting. Michael, do you love it how we inflate the balloon? Okay, so this is the final image here. Look at the valve in valve. There is no turbulence, no leak. Look great. And that's the, here on this side, you can see the pulmonary valve also. So tricuspid and pulmonary in same slides. And look, the immediate RV, I wouldn't say regression, but decompression from the volume. So this is a tric valve that we did yesterday, and for a patient, you can see how many devices I did for her over the last 2 years. So degenerated surgical valve, then valve in valve, that's 2. Mitral clip, very difficult mitral clip, and it was done successfully. And there is CRTD, and then you can see, can you see here? Where is the? Can you see at the tip of the cursor? What is this? This is an ASD device that we have to close the transeptal puncture. We did for before you implant the tric valve, because you are now, after putting the tric valve, which is in the SVC and IVC, you will ventricularize the right atrium. Then if there is a shunt, then there will be a right to left shunt, and patient, they will be hypoxic, and probably manipulation with a recently implanted valve will be a problem. So we close it before. And this is a beautiful angiogram.
If you don't mind.
Khalas, we are done. Yeah. We are done. Thank you very much.
Appreciate it. It's a really nice talk.